get the party started. And if you have questions, you can just type it into the chat to everyone, and Sarah will moderate those.
By the
So
way,
we have,
sorry, Christian, to interrupt. I forgot, which I told you I would. We are recording this so that our field school tomorrow can enjoy your presentation and whomever else into the future. So just so you all know, we are recording.
Awesome. So I have to be on my best behavior. Great. So we have a bunch of folks with different backgrounds. I know AJ down there in Florida is an EMT, and then other folks might not have any medical training. Other folks on here, I'm sure, are wilderness first responders or have other medical experience. So I kept this somewhat broad so it would apply to everyone. So why are we here today? So if you have a medical cert, this is going to be a great refresher for you. Like I said, we'll go over the patient assessment system. So the scene size up and the primary assessment specific to a wilderness setting. And if you don't have a medical cert, you can definitely use these skills. They're universal. And when I say they're universal, whether you're in the front country or the back country, whether you have a trauma injury or a medical ailment going on with your patient, you'll be able to use this patient assessment system to make sure that the scene is safe and then help that individual. And the Good Samaritan Law, which I'll just touch on briefly because this is quite lengthy and varies state by state, but if you do not have medical training, or if you do have medical training and you don't have a duty to act, in other words, you're not being paid money to help someone, you are able to help an individual, and this Good Samaritan Law will protect you legally because you have voluntarily rendered aid to your patient. So patient care, what does that mean? Why is it important? So patient care is just caring for your patient. So when I say patient care, whether you're caring for an individual in an urban setting or in a wilderness setting, when you're working to help them, that's your patient care. And the reason we need to understand patient care is because working and recreating in the outdoors can definitely be dangerous. Like Sarah was saying, I really enjoy mountain biking and snowboarding, and working with ACE, we work with chainsaws, and there have been a lot of times, whether it's coworkers or friends, they've been injured in the backcountry. And I say, thank goodness I understand the patient assessment system, which we'll go over today. And when somebody's injured, you need to be able to respond in a calm and competent manner. Adrenaline makes it really hard to think. If you've ever been in an emergency situation, you see the accident happen, you see the aftermath, and your adrenaline starts pumping, and your sympathetic nervous system starts kicking, and it's really hard to think and have a coherent thought process. So we need a reflex, we need a method that is universal and can kind of give us a logical sequence to follow so that when something bad happens, we can just fall back to that reflex. We can let our reptilian brain just kind of go through the motions. And when I say universal, whether it's urban or wilderness, whether your individual, your patient is old or young, whether it's a traumatic injury or a medical condition, this patient assessment system, or PAS, which we're going to talk about, will lead to a positive patient outcome because that's what it's all about. It's all about helping the individuals that have been injured. So let's dive into the patient assessment system. Like I said, whether you are already trained in medicine or if you have no training in medicine, you can still use these concepts. Today we're going to go through the use of these tools, but we're not going to go into diagnosis or specific treatments because there's no way to get you the hands-on skills and spend the amount of time we need covering this stuff to give you a certification or anything. So this is for your info and you can use it, but we won't be focusing on treatments. We'll be focusing more on the methodology. So the PAS, Patient Assessment System, is a framework used to treat anyone who has been injured or is sick. And this is used by wilderness first responders, emergency medical technicians, paramedics, and folks in the military. For example, the wilderness first responder course that I recently taught had some EMTs and some Army Rangers and some police officers in it, and they were taught these same steps in their own emergency training. So really important stuff. And this is a visual aid here at the bottom, this triangle. This is the patient assessment triangle. At the top, we're going to start. So we have the scene size up. And then we move into our primary assessment where we identify and treat life threats. So today we're going to focus on the scene size up and the primary assessment. And then in future sessions, we can go through the secondary assessment. So let's get into it. So the scene size up, we have a fun little poem here, a little rhyme to remember it. So 1 is I'm number 1, followed by 2, what happened to you, followed by 3, not on me, 4, are there any more, and then 5, dead or alive. So 1, I'm number 1, what's going on here? So we need to make sure that the scene is safe for you and your crew. If the scene is unsafe, you're not going to try to treat a patient. For example, if there's a wildfire ripping through an area and you are going to respond to that area, you would wait until the wildfire was put out. Other examples include wild animals. While a grizzly bear is rummaging through your friend's tent, that's not a good time to go try to help your friend unless you have grizzly bear training and explosive weapons. So lightning, flash flood, if there are explosive materials in the area, these are all examples of when the scene would be unsafe. And again, you want professionals to make the scene safe before you enter the area, or you would want to wait, for example, for that lightning storm to pass before you go in and try to help patients. So again, I'm number 1, you need to make sure the scene is safe. The scene has to be safe to proceed. And then 2 is what happened to you. So here we're forming a general impression of the scene. So what did you see happen to your patient? For example, did you see an individual on their mountain bike run into a tree and get injured? Or what do you see? Maybe you didn't see the actual accident occur, but now you currently see an individual that's laying next to their mountain bike and it looks like they hit a tree. Or if your patient is alert, you can ask them what happened. Or if there's a witness, maybe the individual that called for help witnessed their friend collapse or witnessed a certain accident. So here at 2, what happened to you? We're forming a general impression of the scene. So 1, number 1, making sure the scene is safe. 2, what happened to you? Forming a general impression of the scene. And 3 is a big one, especially in this day and age. 3 is not on me. So body substance isolation, or BSI, is in layman's terms, we're keeping other people's bodily substances out of us and off of us. For example, there are a lot of bloodborne or airborne pathogens or diseases that we don't want to get on us when we're treating individuals. So in the field, how can we improvise personal protective equipment, or what sort of PPE are we going to have available on these ACE hitches? So eye pro, or eye protection, we can wear our sunglasses, or if you're out skiing, you can put on your ski goggles, your eye protection if you're on an ACE hitch. In this day and age, when we're worried about airborne diseases, we can use masks, specifically if we have a surgical mask or an N95 respirator. Those are really great ways to protect yourself. But in the backcountry, if we don't have those things, we can double up with a bandana across the face or buffs across the face. And just make sure if you're using a bandana, buff, or other improvised face mask, that it at least goes from your chin to the bridge of your nose. And again, doubling up on these is the best way to protect yourself. As we've all heard, if you're within 6 feet of an individual who is coughing or talking or just breathing, you are subject to disease. And gloves is a big one. Gloves is something that you should always have with you, those nitrile gloves, those surgical gloves. But if you don't have those gloves, you can improvise with maybe plastic bags if you don't need digital dexterity, or your work gloves. But again, the most important piece of equipment when it comes to gloves are those nitrile gloves, which give you great digital dexterity. And if you're in an unfortunate situation where someone's losing a lot of bodily substances, and there's a possibility of that getting sprayed onto you, you can improvise a gown with waterproof layers, for example, a Gore-Tex jacket or another sort of waterproof layering. And a big one is wash your hands. If you've used those nitrile gloves to treat someone and you have bodily substances on those, that is a biohazard. So make sure you wash those gloves and then remove them properly without putting your fingers onto the surface of the gloves. And then you wash your hands again, probably a couple times after removing those gloves. So PPE is a big one. And in this day and age, there are things called droplet masks, whether it's a surgical mask or a buff or a bandana. And it's not a bad idea to just put a mask on your patients so that they're droplets, so that you're not exposed to their droplets. So common PPE, again, 3 not on me. This one's huge. You need to protect yourself. You can get all sorts of diseases from individuals via their blood or their airborne material. So make sure you're always using that PPE. So making sure the scene is safe, general impression, 3 not on me, by substance isolation, and then 4, are there any more patients? So have you identified all of the patients? It's really easy to get tunnel vision. You see one individual that is injured and you get focused in on them. You need to make sure in an emergency situation that you don't get that tunnel vision, that you have an eye on the entire scene. So you need to identify and treat all patients. So when you have identified your patients and you understand what sort of condition they're in, a more advanced skill is called triage, where you basically determine the priority of care that you'll be giving these patients if there's more than one. And then the evacuation request, if this is a very serious injury and you need to make an evacuation request, whether that request is for a helicopter or an ambulance or a search and rescue crew, just make sure that you have identified all your patients and then identify what patients will need to be evacuated and what sorts of means will be used to evacuate those patients. For example, a lot of helicopters can only fit 1 patient. So if you have multiple patients that are critical, you're going to need to request multiple helicopters. So in advance, you're going to want to find out as soon as possible how many patients you have so you can make an appropriate evac request. So 1 through 4, an important point here is that 1 through 4. So scene safety and size up, general impression of the patient in the scene, body substance isolation, and determining the number of patients. Those are happening before you get really involved with your patient, because you need to make sure that scene is safe before you put yourself at risk. You need to determine what sort of injury you're dealing with from a distance. You can gather more information about that as you go through your patient assessment, but here you're just forming a quick impression. You need to make sure you have your body substance isolation on, your PPE on. You need to determine the number of patients before you get caught up interacting with your patient at the 5 dead or alive phase. So last step here in the scene size up, 5 dead or alive. So we have something called consent, and you can think of consent as permission. So we have express consent. For example, if Sarah was injured and I was hiking down the trail and I saw that Sarah was injured here, I would introduce myself. I'd say my name, my level of training. So my name's Christian. I'm trained in wilderness first aid. And then I would get consent. So I'd say, can I offer you assistance or can I help you? And if Sarah is a reliable patient and she responds, yep, then I have expressed consent. Sarah has expressed her consent and I can help her. Whereas if an individual does not express consent, for example, Sarah, can I help you?
Yes. Oh, I'm supposed no.
Nope. Sarah has expressed that she does not want my help, so I legally cannot help her because it's against her wishes for me to assist her or to touch her. And you can be sued for assault and battery if you don't get expressed consent. Oh. And on the other end of the spectrum, if somebody is in a bad spot, for example, they have hit their head or something else is going on and they are unconscious or unresponsive, you have what's called implied consent, because if they're unable to communicate with you, the courts in the United States are saying most folks would want your help. Most folks want to have a better patient outcome. So we'll give individuals that render aid to individuals that are unconscious, unresponsive, or unable to communicate. We'll give the rescuer protection via implied consent. So there's some legal stuff there. To put all that word vomit into concise terms, express consent. They express, yes, you can help me. Implied consent. If they have a diminished level of responsiveness, you have implied consent. You're able to help them even though they can't talk to you. So here at 5 Better Live, you want to get consent, and then you want to find out what is the level of responsiveness of your patient. So smiley face next to the alert. If an individual is alert, for example, if I'm the patient, I say, my name's Christian. I'm here at the Grand Canyon. It is 2020, and I was hiking and rolled my ankle. That is a alert patient with a great level of responsiveness. So that's great. If somebody is unresponsive, that's bad news. If they can't respond to you, if they're not responding to your verbal or painful stimuli, you're going to have implied consent, and you're going to want to make the best you can with that situation with this patient assessment system that we'll go over. So we just talked about the scene size up. So number one, make sure the scene is safe. 2, what happened to you, getting a general impression of the scene. 3, not on me, putting on my gloves, my mask, my PPE for body substance isolation. 4, are there any more? I'm looking around, I'm asking questions of bystanders. Are there any more patients? And then 5, dead or alive, that's where I get consent to help my patient, and I determine where they're at on that level of responsiveness scale. So that's the scene size up. So if y'all have any questions on that, now's a great time to type it in and send it to Sarah via the chat.
I'm looking at the chat.
We're going to move from the scene size up onto the primary assessment.
I have a question, Christian. How'd you get into this? This seems like pretty scary stuff. I don't like blood, so.
Yeah, not something to get into if you don't like blood. Yeah, just working as a lifeguard way back in the day when I was a little 14-year-old, and then did the Wyoming Conservation Corps and learned about the wilderness first aid, and then got the wilderness first responder, and then in 2015 did the wilderness emergency medical technician course through Knowles. And yeah, I just love this stuff. Loved being in the emergency department and responding to real life scenarios. So yeah, definitely an adrenaline junkie. I never like to see hurt people. I like to help them.
Well, we're all glad people like you exist.
Great. So if there are no questions, we're going to move on to the primary assessment. So again, looking at this triangle on the left side of the screen, this is the patient assessment system in totality. And then looking at the constituents, we have the scene size up. So we start off at the top. No matter what's going on with your patient, no matter where you are in the world, you're always going to start off with the scene size up because you're number one. And then you move into the primary assessment. And then down here, which we won't talk about today, is the secondary assessment. So the scene size up, primary assessment, and secondary assessment all constitute the patient assessment system. So in the primary assessment, you're going to identify and treat life threats. And we use the acronym ABCDE. I love it. It's the alphabet. To be in medicine, all you have to do is be able to count to 5 for the scene size up. 1, 2, 3, 4, 5. And then first 5 of the alphabet, ABCDE. Great stuff. So what does ABCDE stand for? A stands for airway. If someone doesn't have an open airway, that is definitely a life threat that we need to immediately treat. B stands for breathing. If somebody's not breathing, or if they have a problem with their chest or their thoracic cavity, we need to identify and treat that immediately. If somebody has a C circulation problem, I like to think of circulation as the pump, which is the heart, and the pump is pumping around the blood or the fluid. And then we have the containers, which are the arteries and vessels, which transport that blood or fluid. So problems that can go on with circulation we'll get into, but here we need to make sure folks aren't bleeding out and there's not internal bleeding. Make sure their heart is beating. And then D is disability. So when we talk about disability, we're talking about any sort of possible spinal injury, because injury to your spinal cord, which is the nervous tissue, which is protected by your vertebral column. If there's any sort of major injury to that, it can cause disability, which is where the disability came from. And then finally, we have the expose and environment. So to really hammer that point home, so in here, this is the primary assessment because it's of primary importance. These are life threats, and we need to stop and fix those life threats. We wouldn't find an airway problem and then move on to breathing. That doesn't make sense. Airway problem, life threat, you stop and fix it immediately. And for this, we're just going to focus on the methodology and identification of some common airway, breathing, circulation problems, and we're not gonna dive into treatment because we need some hands-on experience and a little more time to dive deeply into that. So just a cursory explanation here. So here's some fancy diagrams. Kind of freaky. I saw that one on the right. I was like, what is going on there? So airway problems. So when I think of the airway, I think of the bridge of the nose to the base of the neck. This is the airway that I focus on during my patient assessment. So if an individual goes unconscious or unresponsive, they can lose muscle tone. So it takes a conscious individual to create movement of their body and to retain a certain muscle tone. So if someone's lying on their back and they're unresponsive, the tongue and epiglottis can actually close over your windpipe. So looking at this fancy diagram over here on the right, hopefully you can see my pointer, but we have the tongue here, and then we have the epiglottis. So when you swallow food or water, your epiglottis closes over your windpipe and diverts all the food and water into your esophagus. So the little blue mark here is the windpipe, and the little red dot here is on the esophagus. So that's why when I go to drink water, I don't choke every time I try to drink water or eat food. It's because that epiglottis, when I swallow, closes over the windpipe and diverts everything into the esophagus down to the stomach. So when somebody loses muscle tone, their tongue and epiglottis can actually close over the windpipe. So we need to open the airway. So everybody take a moment. So just swallow in your normal head position. Easy. And now tilt your head back as far as you can and try to swallow. So that's basically a head tilt chin lift. When we're opening someone's airway, we're moving the head like that. And the reason you can't swallow is because that epiglottis can't close over your windpipe. So that's how we open the airway with a head tilt chin lift. Some other airway problems could be choking. So if somebody's choking, we can do abdominal thrusts to clear the airway. And if somebody has a constricted airway, anaphylaxis is a severe allergic reaction. For example, I have a friend who's really allergic to bees, and if he gets stung by bees, his airway starts to close, his bronchioles start to close. My brother's asthmatic, and I remember he had a severe asthma attack once, and it looked like he was trying to breathe through a straw, and both of these folks received epinephrine, which dilates or opens up the airway. So these are all examples of airway problems, and those are the treatments you would use. So A is airway. Very important that you assess the airway after your scene size up. So we'll move on to B breathing. So B breathing, I like to think of that from the base of the neck to the belly button or the navel. It's encompassing our chest cavity or our thoracic cavity. So some problems here is a flail chest. So if somebody is involved in a very traumatic incident, for example, somebody hits a tree while they're out snowboarding going 60 miles an hour, a flail chest is when you have multiple ribs broken in multiple places. For flail chest, I guess the technical definition is 2 or more ribs broken in 2 or more places on each of those ribs. And they call it the flail chest because it's a flail segment that moves in opposition to the rest of the chest wall. So to treat that, you'd put a bulky dressing on that flail segment to keep it in line with the rest of the chest cavity. And then the sucking chest wound is commonly associated with puncture wounds, whether it's a shooting or a stabbing. If there's an opening in the chest cavity, there's going to be air trying to come in, because when we breathe, we have this closed chest cavity. So air comes in, inflates the lungs. That's great news. If there's a puncture wound on the chest that has compromised your pleural space or lungs, the pleural space is just the area in between your lungs and ribs. You can think of the pleural space as a lubricated layer which allows your lungs to move against your ribs without, it allows the lungs to slide against the ribs without there being ripping and tearing associated with that action.
Christian, if you see me just like fall over, it's because I'm going to pass out listening to you. Just a brief interruption. We have our first question here. Has Christian ever worked on anything like this? A chest wound?
Chest wound? Knocking on all the wood. No, I have not dealt with any chest wounds.
Right here.
Yep. No, thankfully I have not. Yeah.
Okay.
Yeah, but serious stuff, and as uncommon as it seems, ACE does work in a lot of places where there are hunters, and I remember I was on a hitch with the Wyoming Conservation Corps, and we were working on elk fence, and we came around a corner, and there were some hunters with their guns leveled at us, and basically they were chasing a buck, and the buck ran towards where we were, and then they heard us walking through the woods, and they couldn't see us. So yeah, although crazy, definitely a possibility. So good stuff to be able to identify and know how to treat this. Yeah, knocking on wood. And then for the second chest wound, you would put a occlusive dressing or a airtight, watertight dressing over the wound. And then you would tape it on the sides to keep it in place, because we want to prevent air from coming in where that puncture wound is. And a pneumothorax. Pneumo means air, and thorax is referring to your thoracic cavity. So I was talking about that pleural space earlier, that lubricated layer in between your lungs and your ribs. If a bunch of air or blood starts to build in that pleural space, it can actually compress your lungs, and that results in a pneumothorax, which is an accumulation of air in the pleural space, or a hemothorax, which is an accumulation of blood in that pleural space. And as you're probably thinking, yes, these are all critical conditions. So if you're in the backcountry, this is when you're contacting dispatch and you're requesting a helicopter evacuation, because these are quite critical. And then say, this is common with submersions in water. If an individual is submerged in water and you pull them out and their heart is still beating, so they have a pulse, but they're not breathing, you do rescue breathing. So an adult, that's 1 breath every 5 seconds. So again, they have a pulse, but they're not breathing. You do rescue breathing. They need oxygen, they need air, so you give them 1 breath every 5 seconds. And for those of you with medical certifications, at this time due to the virus, you're not going to want to do, well, let me rephrase that. It's considered very high risk to do rescue breathing, whether it's during rescue breathing or CPR. It's high risk to do ventilations, even if you have a face mask or a pocket mask, just due to how easily the virus is transmitted. So keep that in mind, do a really good risk assessment for those of you that have medical certs. So don't want to get off on that tangent. So circulation, so we've gone over airway, breathing, circulation. So we want to check the pulse. So here in the top right corner of the screen, we have an individual checking their radial pulse. So to find your radial pulse, just below your thumb pad, slightly lateral to that large tendon, you just press. You don't use your thumb because you can pick up your own pulse in your thumb. Just underneath that thumb pad, you're going to be feeling your radial pulse. So you can take a second to find that. It's named the radial pulse because it's right next to your radius bone. And then this other photo is the carotid pulse, or carotid artery. So when you're finding the carotid pulse, it's easy on me because I have this enormous Adam's apple, just lateral to the throat, lateral to that cartilage there is the carotid artery where you find the carotid pulse. So if somebody doesn't have a carotid pulse, that's really bad news. If there are no other signs of life, they are most likely in cardiac arrest. So here in circulation, you're checking that pulse, and then you're doing a blood sweep. You're looking for any sort of major bleeding. So you want to stop that bleeding, whether that's with direct pressure or other fancy tools. And then shock is when someone has an inadequate blood pressure. So the medical definition of shock is just a decrease in blood pressure, which means that your vital organs aren't receiving the oxygenated blood that it needs to live for that cellular respiration. So shock is very serious. People need to go to the hospital if they're going into shock. So what does shock look like? Somebody's going to have an increasing heart rate and respiratory rate. They'll have a dropping blood pressure, a dropping level of responsiveness, and their skin's going to be pale, cool, and clammy. Blood is warm and reddish, so I have good flow of blood right now. If I were to be going into shock, this blood's going to be shunted to my core, and the blood's not going to be near my periphery. So I'm going to turn pale, cool, and clammy because all that blood's going into the core. So again, this pulse here is your radial pulse, and this one here is your carotid pulse. So if you're with a friend, you can play doctor and check out those pulses. So airway, breathing, circulation. Let's move on to disability. And again, we're talking about disability. We're not talking about any sort of other disabilities aside from possible damage to the neck or back, which can lead to disability. Because like I was saying, that spinal cord, which is protected by your vertebral column, if that spinal cord is damaged, that leads to an inability of electrical signals to move from your brain to your body. So I like to think of the brain as the computer. It gets signals from the body, which travel up the spinal cord, which is, the spinal cord is the connector between your computer and your body. So if that spinal cord is injured, there most likely will be some sort of disability, which is where this D comes from. So was your patient in a significant accident? Was there a significant mechanism of injury? And I like to define significant as faster than you can run and a fall from greater than the patient's height. So for example, I can't run very fast, but that's a nice way to think about, okay, this person was in a motor vehicle going 30 miles an hour. That's faster than they can run. That's significant. Or this person was snowboarding or mountain biking or skiing, and they were going faster than they could probably run. So this is significant. And then the fall from taller than the patient's height. So if I'm 6 foot and I fall from 10 feet, 15 feet, that's going to be significant. And this varies depending on where you get trained, but this is a nice binary to think about. This is a high risk mechanism of injury, or it's maybe not so high risk. And if somebody has had a significant accident, you're going to want to protect the spine. So how do we protect the spine? It's basically keeping them in the position you found them. It's maybe improvising a loose, definitely loose, soft cervical collar. Those rigid, hard cervical collars, turns out they're really bad for folks with spine injuries. So those are so last year. So now we go with the loose, soft C collars, and then controlling someone's head and keeping their spine in line with the rest of the body. So airway, breathing, circulation, disability. The last one we'll go through is the E, expose an environment. So like I was saying, the primary assessment is where you're treating any life-threatening injuries. So here at expose, we're exposing any non-life-threatening injuries. So if I twisted my wrist or had a dislocated finger or rolled my ankle, those are non-life-threatening injuries. So we need to treat airway, breathing, circulation, disability before we get sidetracked by these minor injuries. So we expose, medicine happens at skin level. So it's not just poking and prodding through the shirt. With your patient's consent, you're going to want to visualize the area that's been injured and do everything at skin level, because that's the only way to really visualize and see what's going on. And then when it comes to the environment, make your patient comfortable. So some great photos stolen from Google here. So if you're in this sort of environment, they're probably dehydrated, they're probably really hot, they probably don't want to be directly in the sunlight. So thinking about how to shelter and provide for that patient. Whereas down here in this more snow, wintry setting, your patient's probably going to want to be warmed up. And this ties into the point in your scene size up, you should be gauging the risk of entering the scene, but here in environment, you also need to gauge, if you haven't already done so, how dangerous it's going to be to not only evacuate your patient, but also to stay in the certain area. For example, if you're in a slot canyon here in Arizona in monsoon season and a monsoon's rolling through, is it safer to treat your patient where they are, or do you want to quickly move to higher ground? Here's a little avalanche here. Probably not going to want to remain in the avalanche chute. So we did the scene size up, which always comes first. And then we do the primary assessment, which comes after you've made sure the scene is safe. You determine the number of patients and you put in your PPE and body substance isolation into action. So if you have any questions about the scene size up or the primary assessment, the airway, breathing, circulation, disability, expose an environment, now's a great time to shoot a little chat message to Sarah.
Shoot it over, or you know what? You can unmute yourself. Let's hear from you.
Whoa, now things are getting crazy.
Oh, come on. What's going on in Florida? Who's over there in Florida?
Hey, how you guys doing?
How are we doing? How are we doing? How's Christian?
Doing well.
Hey, I have a question for you, Christian. It's Midge.
Hey, Midge, go ahead.
Hey, so I'm just kind of overwhelmed by all this, thinking if I came across you or Sarah out on the trail and I was trying, I would just be immediately calling just for air support because, not having any of this background training. So I know this level of class is much higher than where I'm at in my little office. So, so that's just what you're trying to tell us, though, is you're just trying to do a wide range here, right? To be able to let us know, hey, if you don't have any training at all, just call for help. But this is really the level for those guys who already have guys and gals that have this kind of training, and you're just, right? So you're telling me just call 911, Midge, don't.
Yep, in theory, yeah, definitely. So yeah, no official certifications coming from this. Yeah, just like you're saying, we don't have time to run through the specifics. We don't have time to be in person and to go through the treatment. So yeah, just like you're saying, this is great for you to run through, even if you don't have medical training. So Midge, in your example there, if you come across Sarah or I, you can use these skills. So you could go, okay, I remember Christian talked about the scene size up and the primary assessment. So if you write this down or look it up, you can say, okay, one-arm number one, make sure the C is safe, see what happened to you. But yeah, when it comes to treatment, just like you're saying, unless you have a certification, yeah, you're gonna be thinking about airway, breathing, circulation. But at your level, it's probably, if it's serious, definitely gonna be, I'm gonna do the best I can, and I'm going to make an informed call to dispatch, an informed evacuation request.
Sure. So like if you know, if I'm in a wildfire area and someone's injured, you know, because number one is, you know, being safe, you know, it would be really difficult for someone like me to kind of understand, do I move the person? Do I not? You know, so it's it's
sure.
causing me to think about a lot of things, which is really good. I really appreciate it. I'm just laying it out there too, since you're looking for comments.
Yeah, definitely. And yeah, in that case, major number one, that if there's a wildfire going through there, don't get injured.
Yeah, but I'd want to take you with me. So there you go. So I'd still be protected under the Good Samaritan, even if I screwed up, huh?
Yeah, more or less, unless there's
More or
gross
less.
negligence, but yeah, we won't go there.
Okay, cool. Sorry to go off topic there. I was just throwing that out there. Thanks.
No, that's great. Yeah, I appreciate it. It's definitely, this is a lot of information, and this is what we go through in the wellness first aid, wellness first responder, and above. And yeah, just like I was saying, if you want to write down or look up more about the scene size up and the primary assessment, you can use them to make sure that you and your crew are safe and to be thinking. But yeah, we won't go too deep into treatment or anything like that. Awesome. Thanks, Midge. Any other good questions out there?
Just Karen. This is
How's it going, Karen?
going
Hi, Karen.
great.
Where are you, Karen?
I'm the MSC for the Texas branch. So
Woo-hoo. Hey, Texas.
hi. I just wanted to ask Christian, is this going to go over anything that needs to be like currently updated? Any currently updated information that we've already been through? Because I know I just did mine over again.
I love it. Are you talking about in response to the coronavirus pandemic, or just in terms of updates to the scene size up or primary assessment?
Updates to anything that has in the last couple of months.
Awesome. Yeah. As you know, medicine changes, and frequently there are a lot of changes going on, but yeah, this is the up-to-date scene size up and primary assessment, and the updates that are going to come from Desert Mountain, who I teach for, and the Wilderness Medicine Education Collaborative, so Knowles, Aries, Solo, folks like them. They're working on a COVID-specific document that they're going to share with us, and then I'll make sure to share it with you. But yeah, for currently certified providers out there, just know that the most risky thing you can do right now when it comes to coronavirus is enter a scene unprotected and to give breaths, even if you have a pocket mask or a face mask, whether you're doing rescue breathing or CPR, coronavirus goes right through the pocket mask and the face masks. So gauge your risks there, and just remember you never know who's infected. So yes, just treat everybody like they are. Your safety is number one, so make sure you are comfortable with the risks. Great question, Karen, definitely pertinent.
I've got a question for you, Chris.
Yeah.
So do you have any tips as far as like stress management in this sort of situation? Because I feel like there's definitely a lot of critical thinking that's involved, and it can get stressful. So, I mean, how would you manage yourself and manage your crew?
Yeah, and you're talking about an emergency situation, just whether it's a chainsaw accident or yeah. So that's a great question. I love the old Mingo name there. Yeah, the biggest thing is, and this is kind of specific to folks with training, but yeah, knowing that you've been trained in what you need to do, and that it's a reflex. So when I in real life have entered these situations where you just have that kind of out of body experience and your adrenaline's pumping and you kind of focus in on your environment and surroundings, just understanding that this methodology, that scene size up and that primary assessment are what you're gonna roll through, and just hitting them all, because once you start skipping steps, if you skip the one on number one and you enter an unsafe scene, then it all kind of goes out the window. So yeah, definitely know your stuff, practice it, keep it updated, read those papers that come out, stay updated with the emergency medical system. And yeah, if you know it and you practice it, when it comes to the real thing, you feel very confident. And yeah, just if it takes a minute to just center yourself before you jump into action, that definitely does a lot. And yeah, lead by example. If your patient's freaking out, pretty easy to lose your center. So make sure you're staying calm, cool, and collected. That was a long-winded answer there.
I like it. Thank you.
Yeah. Yeah, go ahead, Veronica.
What is the ideal, so there are quite a lot of steps to kind of keep in mind, like you were saying. So what is the ideal time frame from when you see somebody injured and you step in to help? How, what is the, time frame that you should be assessing and then, taking action and something along those lines, I guess. That makes sense.
Yeah, that's a great question. And unfortunately, I'm going to have to do that "it depends" answer. I hope you'll forgive me. But yeah, it's going to really depend on how critical the patient is and what sort of injury or illness they have. And just something that comes to mind where it's like you better hop to quickly, as if somebody has a major bleed going on. You're going to want to really reduce that time. You don't want to skip any steps, so you don't want to put yourself at risk. But you definitely are going to want to treat that quickly because you have visualized and understood the threat. And if you have the tools to treat that, you want to make sure you're getting those treatments on board as soon as possible. So that's going to be a pretty quick reaction to that physical traumatic injury. Whereas if you come upon somebody that has a more medical condition, for example, an elderly individual that's experiencing chest pain and pain radiating to their arms, so it looks like a heart attack, you're not going to want to rush in there. You're not going to want to make a diagnosis right off the bat. You're going to want to really establish rapport. You're going to want to do a really great investigative background where it's like, okay, what are your signs and symptoms? What are your allergies, medications, last ins and outs, events prior? Have you ever felt like this before? So yeah, to answer your question more succinctly, from the scene size up to initiating patient contact in a more critical physical traumatic injury, it should be probably less than a minute, as long as your PPE is more or less ready to go. And then the medical situation, more than a minute. Hopefully that made sense.
Yeah, it did. Thank you.
Yeah, great question. Cool beans. If there are no more questions, I'm going to jump to this real life scenario that I had out in the Sierra National Forest. So take a minute to kind of think about this. You're about 2 miles from the trailhead, and just kind of think about, based on what we've talked about, what do you do? How do you approach this situation? So the scenario is you're chainsawing with your crew when your coworker cuts their hand. They cry out in pain and you see some blood coming from their hand. So kind of take a minute or so to think about how are you going to approach this situation. Okie doke. We have any thoughts out there? What are y'all gonna do? 2 miles from the trailhead, your buddy has just cut their hand and now they're actively bleeding.
Scene size up. Make sure that chainsaw is still off, or if it's still on, cut it off.
Love it.
Also,
Grab
I
some gloves.
want to make sure that they weren't in the middle of felling operations.
Yeah.
That the environment is stable around the person.
Definitely. Thanks, Kat and old Mingo.
Have them put pressure on their own injury while you're getting your PPE on.
I love it. Yeah, so they probably have some bloodborne pathogens in that blood that I don't want to get on me. If they have a bunch of blood and they're bleeding, it's going to take me a minute to run through my scene size up, grab my med kit, put my gloves on. So it's their blood. They can apply pressure to it. Awesome. Any other thoughts out there? Yeah, so kind of a leading question here. Yeah, so you're gonna do just what we talked about. You're gonna do the scene size up. So on number one, make sure that the scene is safe. So like Kat and Mingo were talking about, we want to make sure that there aren't any trees about to be dropped on us. The log's not about to roll. The chainsaw's turned off. The person isn't flailing about with their chainsaw. So number one, make sure the scene is safe. 2, what happened to you? We saw them, they have cut their hand. The mechanism of injury was a chainsaw hitting the hand. 3, not on me. Definitely want to put my gloves on. In this day and age, maybe more PPE if they are possibly contagious via airborne pathogens. 4, are there any more? Are there any more patients out there? And then 5, dead or alive. So this person's alert. We get consent to treat them. And then A, airway, no problems there. B, breathing, no problems there. C, circulation, yeah, problem there. There's blood. And then we continue. Are there any D, disability, E, environment or exposure problems? And this individual, just like Matt Kleberg was saying, yeah, we had them put pressure on their hand while we got our PPE on, and then we treated the wound, and then we went to the hospital. Sutures, sewing people up is definitely outside of your scope of practice, so don't do that one. Let the pros do that. They're gonna wanna clean it really well too. Great, so we can hop back. Cool, so like I was saying, if you have any questions about the scene size up or primary assessment, definitely feel free to shout them out, because we're gonna move on to hyponatremia.
Hey Christian, my name is Dave Hecker. I work with Ace Epic, and I have a question for you.
Awesome, yeah, Dave, go ahead.
So one thing that I've heard in the past, and I've been taught, but I could use a refresher, and that being, as you said, to treat the wound. And so when it comes to applying an antibacterial ointment versus a cream, I'm told that there is one of those in which that is much more difficult for paramedics and doctors to clean out of a wound in the hospital, in which one of those you don't necessarily want. Which of those is the preferred, I guess, material or?
Yeah, that's a great question. So we've kind of shifted away in recent years, at least Desert Mountain. I can't speak for all of emergency services because, as you've probably learned, different places do different things and different papers say different stuff. But yeah, I'll stick to the Desert Mountain response, which is you can use either the cream or the ointment, but we stick to the area around the wound. We actually don't put the antibiotic material into an open wound. And the reasoning behind that is just antibio means anti-life. And what we do to actually clean or purify the open wound itself, which is below that dermis, is we use high pressure irrigation with sterile water. So to answer your question, so if I have a big laceration here, what we're going to do is we're going to use at least 1 liter of clean water, and we're going to use an irrigation syringe, and we're actually going to use at least 1 liter or more to use high pressure irrigation to clean that wound. And then we're going to put the antibiotic material on the outside of the wound. And on that point, we never want to put rubbing alcohol or alcohol inside of a wound. Ouch, painful, kills your cells. We also don't want to use hydrogen peroxide inside of an open wound because that H2O2 actually hyperoxygenates your own cells and kills your own cells as well. So yeah, hopefully that answered your question. And I couldn't tell you which one is easier to clean out the wound, but here at Desert Mountain Medicine, we just put it around the wound. So hopefully that answered your question.
Yeah, thank you.
Yeah, no worries.
I have a question.
Yeah.
So like if you were to not have access to like high pressure irrigation, is it okay to put antibiotic cream or ointment on the wound directly?
Yep. Yeah, in that case, personally, again, the literature kind of conflicts and there are a bunch of different opinions, but yeah, I would much rather maybe hurt some of my healthy cells with that layer of antibiotic than have some sort of pathogen or disease that I don't want proliferate and grow inside of my body. But yeah, when it comes to sterilizing water, we can use povidone or iodine, just like making water we're going to drink. We can use that to sterilize water. We can also boil water. But if we boil water, make sure it cools before you go blasting your patient with it. Yeah, great question. And yeah, just personally, I would use the antibiotic cream if I had nothing else to irrigate that wound with. Great question. Great, so we're gonna hop into hyponatremia. We're moving into summer. And a lot of folks have heard the hydrate or die. A lot of folks know it's really important to stay hydrated, but there's a nice balance that has to be struck in our body because our body is really sensitive to electrolyte or sodium imbalances. So breaking down hyponatremia, hypo means low, Na is the element salt, and then emia is blood or blood condition. So I like to think of hyponatremia as we got low salt blood, and electrolytes include sodium, potassium, magnesium, calcium. And what is an electrolyte? There's this definition here, but the way I like to think about it is an electrolyte is anything that helps carry out a physiological process in your body. So it's anything that's going to be helping facilitate an electrical movement within the body. So when we think about really complex occurrences in the body, whether it's our sodium-potassium pump or depolarization of neurons in our body, pretty much everything we do requires electrical charges to move within the body. So what helps carry those electrical charges? Electrolytes and salt, which is kind of what I'll focus on because that's the best way to reestablish somebody's electrolyte balance is just with straight salt. We're going to want to make sure we have a good electrolyte balance in our body. So an example of how someone can become hyponatremic is we had an ACE individual, crew member, who was working on the South Kaibab Trail in the Grand Canyon, and they were feeling kind of sick. So they weren't eating food, but they were drinking lots of water because it was summer, it was really hot. So they drank a bunch of water, and they hadn't eaten any food in about a 24-hour period. And they had to actually be evacuated from that trail via helicopter because they were entering severe hyponatremia. So another example that's interesting is there was a competition called Hold Your Wee for a Wee out at a radio station, and they sat a bunch of participants down and gave them unlimited water to drink, and whoever drank the most water without using the bathroom would win the Wii, because they had held their Wii for so long. And one of the individuals actually ended up there was a negative patient outcome with one of the individuals because they had just chugged so much water and they hadn't eaten any food. So this is totally real, definitely happens. So beware of overhydration. So the causes of hyponatremia are drinking lots of water and not ingesting enough electrolytes. And keep in mind, you ingest electrolytes when you eat food, whether it's chips, your peanut butter sandwich, anything with sodium, magnesium, potassium in it is going to contain electrolytes. You don't necessarily need to swallow salt pills or put a tablespoon of salt in your water. So signs and symptoms of mild hyponatremia are headache, dizziness, lethargy. Lethargy is when you just feel really tired. You don't really want to do anything. Hunger and clear and copious urine. So clear and copious urine makes sense. They've had a bunch of water, so now they're urinating frequently and it's clear. And then severe hyponatremia is characterized by vomiting, severe headache and lethargy, and something called ICP, not to be confused with the 90s band Insane Clown Posse, although equally terrifying. So ICP stands for intracranial pressure. So intra means within, cranial referring to the cranium, and then pressure just being the expanding volume of the brain within that closed space. So the brain is really sensitive to electrolyte imbalances. So somebody with really severe hyponatremia and a really severe imbalance of fluid and electrolytes can actually have a herniated brain, which is fatal. So as with lots of things in wilderness medicine and medicine, an ounce of prevention is worth a ton of cure. So really keep tabs on your fellow crew members, on your crew leaders, just on your staff, your friends, your family. And if somebody's acting abnormally, it's a great time to question them and to make sure that you're treating their illnesses, for example, hyponatremia, before it gets more severe, because we want to catch things early. So great segue. How do we treat hyponatremia? TX meaning treatment. So mild hyponatremia. So you don't want to give these folks water. If an individual has if they're alert and they can chew food and swallow it, just having them eat salty food, salty snacks is a great way to get some energy and some electrolytes on board. I'm a big fan. Speaking of running races, the first ultramarathon I ran, for the first 10 miles, I was drinking water and not eating food. I started feeling really weird. And then I just took a salt pill and poured some table salt into my water bottle for some electrolytes because I had no appetite. And I was drinking a bunch of water and losing a bunch of fluid. And when you sweat, you also lose a lot of electrolytes. That's why you'll see those kind of salt stains on your hat. So no water, salty food, or electrolyte paste, and rest. And if somebody has severe hyponatremia, again, no water. And if they are conscious, if they're able to chew and swallow, probably giving them licks or just a paste of salt is better than trying to get that more severely hyponatremic person. Probably better than trying to have them eat a full meal because they might not be able to keep it down. But if they can, that's great. And then if somebody's severely hyponatremic, so they have vomiting, severe headache and lethargy, and are showing signs of intracranial pressure, you're going to want to evacuate those individuals. So a question for the group. So looking at signs and symptoms of hyponatremia, headache, dizziness, feeling really tired, what else does that sound like?
Heat exhaustion, I think.
Yeah, heat exhaustion, dehydration, acute mountain sickness. So how are y'all going to differentiate hyponatremia from dehydration? Kind of using that as a question.
You gotta ask them.
Hey, what are you going to ask them, Kat?
What their ins and outs were like today.
Awesome. Yeah, ins and outs. So how much food have you had to eat today? How much water or how much fluid have you had today? And then outs, it's not just have you peed, have you defecated, it's how many times have you urinated today? Is that normal for you? What was the color of your urine? Was it frequent urination, or have you only peed once and it was just a couple drops of orange? So really getting in depth and being a good rescuer and being the Sherlock Holmes. Awesome sauce. So that kind of wraps up the intro, the scene size up, the primary assessment, and hyponatremia, which is a common environmental illness. And again, even if you don't have medical training, you can still understand the methodology of the scene size up and the primary assessment to make sure that you are safe as the rescuer, and to be thinking about, does this person have a critical airway, breathing, or circulation problem? You might not be able to treat it, but you can identify it and make an appropriate evacuation request. So I'll open it up to any questions. And if there are no questions, then we can hang out online.
Great
So
job,
I don't know if you're like me, I'm a
Christian.
social butterfly. And cool, any questions?
I've got a question. So what about something like skin tinting? It's like with like heat exhaustion. You pull your skin like that and it stands up. Would you see that with hyponatremia or no?
No, actually that's, if I remember correctly, the dehydration is actually going to be the one causing more of the skin tenting. And for, I don't know if folks see that. So skin tenting is when you pull up on skin and then it just stays there kind of like a little skin tent. So yeah, hyponatremia in folks that are severely hyponatremic, you might see some swelling, for example, swelling of the hands, but not very common. And I think the sample or the patient history will do you more good than the skin test. Great question, love it. Great, Sarah, do you have any closing thoughts for us?
Fascinating listening to you. I'm so appreciative of your knowledge base. I mean, I think ACE Solutions, any one of you, our colleagues here today, members that have experience or are learning, I mean, I'm just grateful for all of you because, yeah, I don't know if I would ever get into the field that you're into because, as I said earlier, I can't stand blood, but I'm so grateful. Thank you.
Blood.
Yeah.
Well, Sarah, we can't hang out outside doing crazy things.
I know.
Gotta be able to help me.
We're gonna get back there someday soon. So it's 5:17 my time here in Los Angeles and in Flagstaff, and let's just keep the communication flowing, and we hope to host many more of these. We also have an opportunity through our EPIC program as well, where they've launched some virtual sessions too. So we're going to merge, we're going to marry, so that everyone can take advantage of this opportunity. Right now, if you're staying at home and safe, we want you back here. We want you get you back into the field as soon as we can. It's hard for us outdoorsy folks to be inside right now, but we definitely want to keep in touch, and we need you. We've got work piling up, so can't wait to get you back.
Yeah, I totally second that. Stay safe, stay healthy. I'm really stoked to see y'all back in the field and get some good work done. Because like Sarah's saying, we have a bunch of great projects. Now we just gotta make sure it's safe.
That's right.
Looking forward to it.
Thanks, Christian. Thanks for launching this new project. I feel like we've had like a Chamber of Commerce moment. We just, broke the ribbon here to our virtual program. Ooh, could I do would everybody turn their video on and I could do maybe a little group shot if you want? That'd be fun, just for history's sake. There's everybody. Okay, let me get the little chat. By the way, Ian
Look at all
called
those
you.
beautiful people.
Ian called you a rookie early on when you were talking about, I think, running and dehydrating and all that wet stuff, salty stuff. Okay, is everybody ready? All right. On the count of 3, I always say I want you to say trees. You don't have to, but I will. Okay, 1, 2, 3, trees.
I want you to say save trees.
Save trees. Thanks, everybody. We miss you. Have a great evening.
Adios, y'all. Thanks for showing up.
Bye.
Bye now.